Welcome to a basic introduction to mechanical ventilation. This is chapter 7.3, PEEP and weaning for COPD. In the last section, we touched on the importance of PEEP in the ventilated COPD patient. Patients with COPD can have significant intrinsic PEEP because of the expiratory flow limits and airway resistance. If the set PEEP is greater than the intrinsic PEEP, then hyperinflation will occur and you will actually cause direct harm from your application of PEEP. But if you closely match the PEEP and don't exceed the intrinsic PEEP, then the patient can easily trigger the ventilator and not increase their workload. As well, trying to match the PEEP provides some benefit in improving VQ mismatch and oxygenation, but in reality this is more of a secondary goal. Although not a focus of the acute phase of a COPD exacerbation, weaning should always be part of your game plan for the management of your patient. The majority of patients with COPD will wean from mechanical ventilation quickly and fairly easily, but difficult to wean patients are not surprisingly associated with a higher mortality and risk of very poor prognosis in the intensive care unit. When patients fail a weaning trial, it's usually because of the work of breathing exceeds their ability to generate the necessary muscle power to do that work. Persistent hyperinflation also increases the load and is a major determinant in the weaning success. Therefore, the success of weaning depends on reducing the load of the muscles with the ventilator and increasing muscle power by providing rest with graduating work over time. At the same time, focus on treating the underlying exacerbation with the usual therapies of bronchodilators, steroids, and antibiotics, in addition to regular sedation vacations and early mobilization.